Good evening, ladies and gentlemen, and welcome to a rather balmy 28 degrees in Toronto. I hope the rest of Canada is enjoying a late summer. Hello, my name is Douglas Queen and I'm the Director of Strategic Planning for the Canadian Association of Wound Care. It is my pleasure to welcome you to today's webcast, entitled A Smart Solution for Diabetic Foot Ulcers, Wound Closure When Time is of the Essence. In today's webcast, we will discuss the indications, use, and patient selection criteria for Integra Dermal Regeneration Template, or IDRT, become familiar with that acronym, in the management of diabetic foot ulcers. We will also review the Founder Study, which stands for Foot Ulcer New Dermal Replacement, and explores barriers to the use of advanced therapies in the area of diabetic foot ulcer management. I am pleased tonight to introduce Dr. John Lantis. Dr. Lantis is the Vice Chairman of the Department of Surgery at Mount Sinai West and St. Luke's Roosevelt Hospital in New York City, where he is also the Chief of Vascular and Endovascular Surgery, where he previously was the Director of Surgical Clinical Research. He also holds an academic title of Professor of Surgery at the Icahn School of Medicine at Mount Sinai. Dr. Lantis' clinical practice spans the field of vascular and endovascular surgery and lower extremity wound healing. He directs a clinical basic science research program in the field of lower extremity wound healing and tissue repair, and has published extensively. He is also a founding member of the American Board of Wound Medicine and Surgery. He currently sits on the editorial board of Wounds and the Journal of Wound Care. To date, he has been the principal investigator in more than 55 multi-center and single-center chronic wound and vascular surgery trials. So, ladies and gentlemen, before I hand the presentation over, I would like to note that we have allocated some time for questions at the end of the webcast, and we look forward to addressing them after the formal presentation. I will now hand the presentation over to Dr. Lantis.
Good evening. It's my pleasure to be here, and I thank you for joining us. I'm going to discuss the use of Integra Dermal Regeneration Template for all types of wounds, those of the acute nature and those of the long-term nature. We'll try to make sense of what we're doing and why we use the products that we use. There are a variety of disclaimers I should point out. I am here certainly courtesy of Integra Life Sciences. We have a large amount of funding from a variety of commercial entities, and I am here representing Integra this evening, not representing my university or my medical center. With that in mind, we have specific objectives that we are really going to look at. Why does dermal regeneration matter? Why are we not just simply trying to epithelialize the wound? We want to explore the mechanism of action of dermal regeneration and the importance it plays in closing both the acute and long-term wound. We want to understand the clinical data, how we can use that, and how we can help our patients heal faster by using the information at our hands. Our current practice at our location is 5 vascular surgeons, all faculty appointments, who are interested in a variety of vascular surgery, but focused to some degree on wounds through at least 2.5 of our practices. We have 8 podiatrists who work with us, an infectious disease team, although in transition, a very important portion of our wound care practice. We have a variety of WOCNs and other practitioners who help us on our day-to-day care of our inpatients, and then we have general surgery and plastic surgery available to us as well. Our overall volume is 10,000 patients per year, with about 50% of those being vascular and 50% of those being wounds. In every given year we do 800 inpatient cases in regards to tissue regeneration, tissue debridement and replacement, and about 500 outpatient cases. Our overall hospital, it represents 600 beds with 11 OR days a week, or if we look at that, so we have 2 OR days every day with 2 surgeons in the operating room. And we have 8 wound clinic days per week. The inpatient census is 16 to 20 patients. About 50% of those have wounds, so a fairly busy wound care practice. Enough about us, though. Why do we treat the wounds the way we do? Well, most wounds are full thickness wounds. They have a significant defect in the dermis, which is going to run down all the way to tissue that we really need to cover. We spend a lot of time reepithelializing wounds and studying the reepithelialization of wounds. However, the wounds are not going to stand up over time without good dermal regeneration. The depth of the injury is significant in these wounds. I think we're all very familiar with this, and we're aware that the tissue is usually damaged all the way down, whether that's a diabetic foot ulcer, where the tissue is broken away from external pressure with the insensate foot, to the venous stasis ulcer, where the tissue is damaged from the inside out. These full-fit thickness wounds are a significant problem, and until we regenerate the dermis, we're going to have a significant problem with epithelializing those wounds and having them stand up over time. Obviously, there are a whole host of things that are available to the surgeon, and we can start with primary closure. We can possibly start with skin grafting. We can do flaps, but a lot of patients are not appropriate candidates for flaps or other tissue advancement strategies because they're chronic wound patients. And we know that the chronic wound patient is a patient who is ill in total. The wound is usually only a portion of this. In the inpatient setting, we often need to take the patient, debride the patient appropriately, and then help them close, starting at the basement layer and working our way out to get good tissue regeneration. Now, certainly free flaps can be a very nice way of doing this, but they're costly, time-consuming, and if they fail, that's a significant problem. Local flaps can also be a nice trick, but not always does the patient have appropriate tissue in that setting to have a local flap available to them. So for us, using an IDRT or using some form of dermal regeneration that we can place into the wound bed and help regrow the skin is very important. And there are some unique properties out there. As you know, there are not many things that we have available to us as types of tissue that we can put into the chronic wound or acute wound bed to help actually regenerate dermis. Uniquely, a collagen product that is then engineered and cross-linked, also with a chondroitin sulfate, has been available for a long time now, and I've been using it for 16 years. It has an overlaying silicone layer that helps reduce the overall fluid transition from the patient's body to the external environment, which can be very important, especially in some of our larger wounds, as we'll see later. One of the unique properties of this is the collagen actually breaks down, or is engineered to break down at the same rate at which the skin regenerates its own dermis. And this is, of course, not always perfect, but it's a unique strategy and was very unique when it was thought up over 25 years ago. The composite design is really in the category of a biomimetic design. In other words, it was something that was engineered to try to mimic the way our body works. And this was really thought up by a burn surgeon and a basic scientist who were trying to come up with a way of treating chronic burns by having something that could act like skin as a moisture and vapor barrier and then allow for healthy generation of dermis on patients who are massively burned. So this unique pore size that was designed and engineered probably does have an optimal structure. That's not well defined in the literature at the moment, but in general this allows for cells to come directly into the dermal regenerative template immediately after debridement or application and fill that template and then go on to generate a neodermis that we can go on and epithelialize, or in smaller wounds, as you will see, epithelializes by itself. On the right-hand side of your screen, you'll see a little graph that shows the degradation template, and interestingly, this product was engineered to degrade at the same rate as the skin was regenerating. And this is obviously quite hard to do, but a very unique strategy. And you'll see pictures somewhat like this one in the middle, again a couple times in histology, showing that when we close the wound with a product like this, we have something that looks much more like dermis than like scar. Now, functionally, if you put this into a cartoon, the dermal regenerative template works very nicely. You affix it. Usually we pie crust it in some form. In other words, we put holes in the silicone, or it comes with holes in it, but we usually just fenestrate it with our own 15 blades, etc. We put it into a well-debrided bed, and we'll comment more on that later, on a nice healthy bed with some moderate bleeding in it, but not a significant amount of blood welling up in it. It's then affixed with staples, and once in place, it's going to have the cells move into it fairly quickly. This is in part secondary to its unique porosity. The fibroblasts will migrate into that cellular bed. Those myofibroblasts will come in, macrophages will come in, and eventually you'll get neovascularization as endothelial cells come in, and the nearby vasculature starts to turn into something more mature. The fibroblasts will synthesize appropriate substrate, cytokines, attracting other portions into the area, creating this much more functional dermis than we see with traditional secondary wound intention. With that in mind, we'll use something like a dermal regenerative template pretty quickly after major resection. Many of our patients who had major foot resections for diabetes mellitus, severe infections, or post-trauma, we really try to speed along the regenerative process with early application of IDRT, sometimes in conjunction with other therapies that we use in the inpatient setting as well. Here also in cartoon form, you'll see this neodermis being formed. It looks in this cartoon somewhat like underneath, but it's really in conjunction with the IDRT therapy. You think of this as a paste filling the wound that allows for the influx, and really, as I explained to my residents and students, almost as the building contractor telling the trucks where to back up and put the important parts in to help build the structure, the superstructure of the skin that allows us to go on and then close the wound. You note at the bottom of this slide there's a comment on small wounds that we allow for wounds to close usually with, we think, endogenous keratinocytes. So in other words, in our practice, this is usually wounds under 4 square centimeters, and you'll see in some of the literature I present later that it's actually going to be in some of the other larger wounds that you'll actually get epithelialization over this IDRT. However, our experience is in a lot of our significantly larger wounds, which may range from anything from 10 square centimeters to 600 square centimeters, we really generate a dermis, and then we close it later with a split-thickness skin graft or some other skin therapy, whether that's a epidermal bullae grafting or some other technique. You'll see here in this real-world picture of a patient who's actually had originally had tendon covered in this setting, and you'll see the silicone being taken off, and usually the silicone is taken off of this outer layer in the 14 to 21 day period, depending on also again how the patient's doing, the shear factors that are affecting that chronic wound, and other ancillary therapies that are being used. Other pictures that you'll see here that are representational of this therapy, you'll see one from a plantar diabetic foot wound, very classic, and the one on the picture on the left is actually from the Founders trial that was alluded to before, and I'll be presenting, but the diabetic foot ulcer trial where the wound was widely debrided. The Integra product, or the dermal regenerative product, was placed directly on the wound, stapled in place, and then you can see the epithelialization not that well occurring underneath the silicone, and then going on to have good closure, and 3 months post therapy, complete closure and almost no scarring. The patient on the other side has a very odd vasculitis of his skin, and is actually otherwise a very healthy. He's actually very unlike your average chronic wound patient, actually a very avid bodybuilder and professional bodyguard who had one bad foot. Actually, by way of story, flew back in from Turkey after bodyguarding for someone that we all know, and came into New York with a terrible foot, an exposed tendon, and we were able to treat him over time with IDRT in the operating room and then skin graft him. So this is a bigger wound that required skin grafting to help close it, whereas the other wound closed by endogenous keratinocytes. So the product can be used in both settings with a slightly different strategy. Now, at times it comes up, folks will say, well, there aren't that many studies looking at using Integra, dermal regenerative template type therapy in the lower extremity, and that's actually not true. I'll be presenting the driver trial or the Founders trial secondarily. First, I want to comment on Dr. Gottlieb's trial, which is really a retrospective trial of 111 patients looking at lower extremity wounds with a whole host of different types of wounds, really. The other studies in here that are very interesting to me, if you look all the way down on the fifth one on the left-hand side, you'll see a single-center retrospective study of patients with also lower extremity wounds. That these were really used, and one of the first publications talking about how much better skin grafts did over Integra. And then you also see that there's a trial in looking at using this on heel ulcers, and specifically that's an area of interest to me, and heel ulcers are very hard to close. So those heel ulcers underwent significant debridement and then were treated with IDRT therapy prior to closure. So many studies out there looking at chronic lower extremity wounds and relatively acute ones. Dr. Gottlieb's trial itself was, again, not really a trial, but a retrospective review of his experience, but very vast experience, but interestingly done with some wonderful histology and other work, and I recommend that paper to any of you who have a chance to take a look at it. 111 patients, as noted already. Interestingly, 71% of them completely healed with no secondary surgery. 20% had significant wound size reduction, but 14% of those patients went on to have Integra, had another skin graft or something of that nature, and 6% went on to just close with a kind of a delayed secondary intention, and only 9% of patients remained unhealed. And this was really because these patients, again, this was not a prospective randomized efficacy study. These patients were very real-world patients like you and I treat, patients with poor diabetic control. They had various other problems, obesity, maybe were on oral steroids, corticosteroids for some sort of inflammatory process, etc. So these were, this was a real-world experience. Interestingly, what happened when they took these patients was that most of these patients did not need other significant inpatient services, so they were able, after debriding them and applying the dermal regenerative therapy, to really keep them out of the inpatient system, which is a significant cost savings for any of us in any of our healthcare systems. Now, I mentioned earlier that when you treat a patient with a dermal regenerative template, you get something that looks a whole lot more like skin than like scar. If you take a look on your slide at the top left is a picture of a wound that is healed by scar. And you can see that there are linear patterns of fibroblasts and other scar-related tissues that almost look like they're streaming in a stream-like fashion. If you take a look in the middle panel, that's what native dermis or real dermis should look like. And you can see that the wound closed with a dermal regenerative template, as you see on the right, has a significant homology to the wound in the middle, where the native dermis, as you should say, which is really not a wound but is sort of a control biopsy. So Integra, when used correctly, or a dermal regenerative template, when used correctly, will have a wound that closes looking much more like dermis than looking like scar. Obviously, inflammation plays a key role in healing, and another portion of Gottlieb's paper, which I'm not going to spend a lot of time on, is that when you treat a wound with a dermal regenerative template, you often get the surrounding tissue to think that it is actually seeing self, and the inflammation can be knocked down significantly. I actually just took some pictures the other day, which didn't make it into the slide deck, of a gentleman with a very badly inflamed ankle ulcer and an open ankle joint, who, when we used a dermal regenerative template on him, the erythema surrounding the wound went down dramatically. And although I don't have histology on that because he's not in a prospective trial at my place, I'm sure that the histology would show decreased inflammatory cells. So it's interesting what this dermal regenerative template may do to other histological components of the wound healing pathway. This is actually a picture also from Dr. Gottlieb's study showing a patient who had a leg ulcer of probably mixed etiology. This is not a true venous stasis ulcer. This patient's had multiple venous thrombotic events, pulmonary embolism, etc. But in short, most likely this is a multifactorial skin condition of vasculitis, which in a recent paper from the Georgetown group, these type of ulcers have been shown to only heal about 23% of them will close over a 2-year period. So really abysmal numbers, and all of us have to deal with these type of numbers and these type of patients, and they're very distracting to us. So one of the options here is obviously to take them to the OR, to breathe them widely, and use a dermal regenerative template. And I think there are some actual cost savings in regards to this type of therapy for these large ulcers as well, because what happens is if you don't heal them, they stay in the outpatient environment forever, fundamentally. Now, looking at the rest of these studies, there are a large grouping of small ones, but at the top, Dr. Driver's study, where she was the PI on the Founders trial, is really the largest prospective randomized trial looking at a cellular and tissue-based therapy for diabetic foot ulcers ever published. So you have to say that this is a pivotal trial. It met all the guidelines in the United States for appropriate labeling, etc., which is obviously thought to be quite a rigorous process. So we'll go over that in a moment in detail, but when we are at our place thinking about when to use IDRT therapy, we're really thinking about patients who may be a candidate for grafting, advancement flap. They may not do well with advancement flaps. There might be a patient that we would use tissue expanders on and then advance those flaps. But at other times, an example here would be certainly over a below-knee amputation. It's dehisced. We debride that and use IDRT therapy with great results instead of using things such as tissue expanders or Z flaps, which are other ways that we have about going about this. However, the wound that we treat has to be well perfused as best as we can. The bioburden has to be well controlled, probably through serial debridements and topical antimicrobials. And you want to deal with the underlying pathology. And one good way to do this is often in the operating room with a wide debridement, and you break down the surrounding tissue, take away the bacterial burden, get rid of the senescent cells, and then regenerate the tissue with appropriate dermal regenerative therapy. So for a patient like this who had had a massive degloving injury secondary to an MVA, we take them to the OR initially. We did a source control operation in the middle of the night. We took him back to the OR the next day, debrided the wound, and covered it with dermal regenerative therapy. Actually bolstered that with negative pressure wound therapy. Went on and we see these pictures at the end of the talk as well, but went on in that third panel is immediately after the patient has had the silicone taken off, and then the fourth panel is with a relatively raw skin graft on the patient. So our goals when using IDRT therapy is really to enhance the granulation bed and cover structures with something that is thicker and a better structured dermis or dermis-like tissue so that we can go on and close it, that will allow for long-term functionality, and that's the key, is long-term functionality, so these patients don't break down again and they don't need future augmentative therapies. I mean, they may well need offloading, they may well need compression. You have to continue to always treat their underlying pathology, but in general what you're not trying to do here is take them to the OR and just give them the fastest thing, because it's you want really long-term functional care. And for the patients, again, with ulcers or wounds that are bigger certainly than 100 square centimeters, they're going to need a secondary therapy to epithelialize, but they're going to have a much more durable outcome, and that's what we're very interested in. However, I'll be making some comments in a while that when you are using dermal regenerative therapy, it's far superior to many of the other ECM type therapies or even bioavailable therapies where you have to put on multiple applications, because dermal regenerative therapy in general is as we like to say, a one and done therapy. You put on one application and you get an awful lot of bang for your and a good result at that period of time. The indications are relatively significant for us and wide-ranging. We use the bilayer with silicone backing under negative pressure wound therapy for a minimum of 4 days in most of our patients. And then for deep punctate wounds, we also will use a injectable. We find the injectable to be very good at filling space, and we leave that on for 21 days prior to micrografting. We're quite happy with silicone overlying that, and we think that we keep the silicone in place in both of those indications. Of note on this slide that the number of applications is only 1, and the location of application for most of these wounds, especially wounds that are larger than, we'll say, 10 square centimeters, is almost always in the operating room. So there are a number of other comments in regards around skin grafting, and I think most of us are aware of this. Since about 2007. There have been a couple of different papers looking at improved graft take with split thickness skin grafting after using a dermal regenerative therapy. And we have been strong believers in this. What we fundamentally do, again, is a protocol. Both Bransky, Yao, and Men have all put this into nice criteria, and what they really looked at is well debrided, appropriately prepared wounds treated with IDRT, often treated in conjunction with negative pressure wound therapy. The silicone is usually lost or removed at 14 to 21 days. Potentially another week has gone by before they're skin grafted, and skin grafted at about 4 weeks post-application. although I think some of these papers and we ourselves are experimenting with skin grafting at a more early stage and trying to push that envelope along. But I don't have the right answer for you on when to skin graft or epithelialize these wounds as of yet. Now, I think you've heard a lot about this so far during our talk, but mentioning Dr. Driver's study, as I referred to it, or the Founders Trial, the foot ulcer new dermal replacement study. And this study fundamentally really is a well-designed, beautiful, prospective, randomized trial that fits all the criteria that everybody says, oh, I need a big randomized trial before I'm going to believe anything. Well, here you have it. This is looking specifically at diabetic foot ulcers. And remember, these are ideal diabetic foot ulcers. These are diabetic foot ulcers where the patient comes to your office every appointment. They wear their offloading shoe all the time. They take care of their hemoglobin A1C. They don't eat crunch bars for lunch. They don't put 14 sugars in their coffee, right? So the point is that not all patients fit these criteria. And there's some key things, like if you can't offload a patient, you can't expect IDRT therapy to be the miracle. If you can't control the patient's sugar and their hemoglobin A1C is 17, you can't expect a miracle. And I think it is important, when we as clinicians get some of these products, we're like, well, it worked on Mary, how come it doesn't work on Bob? And the reason it doesn't work on Bob is Bob wears his work boot every day because he has to take care of his family, but he's got a Charcot foot, and so he can't offload. So we can't expect too much from any one entity. With that in mind, when you look at the trial design, you have to look at the control arm within that trial and think about what the data you're going to see. So this is a FDA, basically an IDE, as we call them in the United States. The FDA and the company meet together to decide that this is how the study should be. So it's about the most rigorous study you can set up in the U.S. as a prospective clinical trial. 307 subjects, 32 sites, so no one site was contributing 80% of the patients, and certainly we're aware that some of the bioactives available in the U.S., they're almost one-site studies, which has its own concerns. I do one-site studies, and they have their own concerns. I'm not trying to cast aspersions. I'm just saying you need multi-center study. There was accelerated wound healing with a significance at the 5-week mark seen in this group versus standard of care. And interestingly, this is one of the very few studies that shows that the patient's quality of life was actually enhanced in the treatment arm. And that's a very rare thing to see, and I'll comment more on that in a bit. So as far as the study design, a very nicely designed study. Screening process was an appropriate roll-in period of 2 weeks to make sure the wounds didn't just get better because of good care. They were debrided and offloaded. And actually, a large number of patients can be lost to this type of roll-in. So it's important to have a roll-in period where the patients have a debridement phase and an offloading phase. In the U.S., that's very important too, because one of the things that happens in the U.S. is we have to wait at least 4 weeks of good standard of care prior to our big payer in the U.S., being Medicare, being willing to pay for any sort of cellular and tissue-based therapy, because they want you to see that quote-unquote standard of care has failed first. Then over the next period of time, they underwent the treatment phase up to 17 weeks. This usually was started with one application and then just was followed over time. And we'll comment on that the majority of these patients, 72%, only had one application of the product. These are the patients that closed, I should point out, had one application of the product. And then a follow-up phase that went out to another 3-month period. So the screening process showed that the wounds were chronic and hard to heal, or at least chronic in nature. Quite frankly, hard to heal definition means that they have to be open up to 50 weeks and that they are larger than average on size. And you'll see in a moment that there's some interesting things about this study compared to some of the other studies that actually might make hard to heal an actual claim as well. It's not an actually claimable thing in the U.S., but it is something that some of us write about, hard to heal chronic wounds versus just chronic wounds. The safety and efficacy was obviously tracked appropriately and met the FDA guidelines. Now, how was this done? The wounds were sharply debrided. The IDRT was usually stapled in place, and if any of you who say, geez, putting staples on the foot sounds like a bad idea, anecdotally, I'll tell you a very brief story, that when I heard about the trial, I said, boy, putting staples in the foot sounds like a terrible idea. You must be blank to have thought of that. Well, it turns out that in 2007, I'd done a small study of using IDRT on diabetic foot wounds. So I said, and besides, I was doing this back in 2007. Why are you guys so fancy? And I said, I'll show you the pictures to prove it. So I opened up my phone, and they weren't there, so I opened up my computer and took out the pictures, and sure enough, I had stapled the IDRT into all 10 patients' feet. So I was like, okay, well, I guess we're all fools. But anyway, point is, actually it works better. Stapling helps you conform the IDRT into small foot wounds better than suturing. Is much easier. My residents, my fellows, and me personally feel so. So I think, and it turns out in the study that the patients who had it stapled, although it's not really talked about in the paper, they had less loss of the silicone portion of the dressing. You can't talk about the rest. You can only tell the silicone, so we'll talk about that in a moment. There's a non-adherent gauze layer placed directly on this, fundamentally by brand name, Diabetic, and that's what we use in our center, and then an outer gauze wrap with an immobilization component. But do not forget that these patients were offloaded, and they were well offloaded. Okay, and then they were followed up. Now, the breakdown of this, as you might expect, there were 545 assessed patients that they were checked for eligibility. A lot of these patients were not eligible. As you can see on the top right, the primary reason that the patients were ineligible was their wounds actually got smaller during the run-in phase, and this is true. We find this to be true in most of our prospective diabetic foot ulcer trials. And then the wounds actually got too small. They got smaller than 1 square centimeter, which again is actually very similar to most of the other diabetic foot ulcer trials. These are the same reasons patients usually don't proceed into the trial. 307 patients were randomized, 153 in the control arm, and then 154 in the active arm, as you'd expect. And 128 completed the treatment phase in the active group, and 117 in the control arm. And then the follow-up phases, again, would be slightly less. And all of this is what you'd expect statistically, and was all within the parameters of the study design. Now, this is a busy slide, but I do want you to look at a couple things. One is, there are a couple parts at the top that are going to say all the things that you expect, that both groups were very similar. There was no difference between gender, age, smoking, etc. There was no statistical significance between hemoglobin A1Cs. And their hemoglobin A1Cs that you would expect in a prospective randomized trial were quite good. They were in the 8 range, 8.2, etc. And these are going to be very, very low compared to what we're usually treating. Interestingly, also the age was in the 55 range, so actually in the U.S., not actually in the Medicare group as much as you would think. But it's also true that most diabetic foot ulcers actually occur in the working population, which people sort of forget about. Now, a couple of points here is that these ulcers are somewhat larger than ulcers in previous diabetic foot ulcer trials. The average size of most diabetic foot ulcer trials is about 2.5 square centimeters, where these were 3.6, which is just interesting. But most notably is this, that the mean number of days, not the median, but the mean number of days that these ulcers have been open were almost a year, or 300 days. And 50 weeks is usually the defining number for hard-to-heal ulcers. So these ulcers have been open much longer than ulcers in most other studies. Now, there's no difference between these two groups, but these are patients who truly are going to need some therapy, and that might speak to why this did well. In addition, these patients are not Wagner 1, they're predominantly Wagner 2. There are Wagner 1 in there, but most of them are in the 70 to 75% category, and then most of them are also in the plantar category. And actually, there's no data in the English language literature saying that plantar diabetic foot wounds are harder to heal than dorsal diabetic foot wounds, even if you look at the Northern European literature, which is quite good about this. But we all have the sense that a plantar diabetic foot wound is harder to heal than a dorsal diabetic foot wound. So again, these were similar things. And then finally, do note that in the types of wounds, there were very few calcaneal ulcers. So these are midfoot, forefoot, and some hindfoot ulcers, but not heel ulcers. And I think that's important to keep in mind also when you're generating your expectations around this therapy. In the question period, I'd be happy to answer things about calcaneal ulcers and how you can use IDRT in that therapeutic window, but that we can leave that to the question period. Of note, also, the patients actually that were healing, the group that is healing is in the dark green, 51% healed at the end of 16 weeks versus 32% in the standard of care arm, but statistical significance was actually reached at the 5-week mark. So at 5 weeks, there was a significant improvement in the healing rate by those being treated with IDRT. And this is also bears out that there was a 3.3% or times, not percent, sorry, 3.3 or 330% actually, but 3.3 times more likely to heal if the patients were getting IDRT. And then the relative improvement in healing was 59%. So the absolute improvement in healing was 19%, and the relative was 59%. So a significant improvement any way you cut it in the patients treated with IDRT. And there's the significance bar that you see with very significant difference in the healing rates, again, starting as early as 5 weeks. Now also, the average wound size reduction with those treated with Integra was 50% faster, at approximately 7.5% area per week versus 4% area per week. And those that closed, they actually closed 5 weeks earlier. And the thing that I think we have to think about when thinking about health economics is that 5 weeks of nursing time has differing values. In the U.S., 5 weeks of nursing time, it would work out with home nurses on a daily basis, and then, which is usually going to be through a visiting nurse service, as we would say, and daily basis in the New York environment, and weekly doctor's visits for that open ulcer. We'll just say that it's a 5-week difference, or 35 days, works out to about $4,000. From getting some of the data in regards to Ontario, my understanding is that home nursing visits would run in the $60 to $70 Canadian dollars per day with travel. So we'll just say 3 visits per week. Plus a clinic visit per week, and you work out to about 2,000 Canadian dollars. So either way you cut it, even if you use the aggressive number or the non-aggressive number, 5 weeks of care, let alone chances of hospitalization, infection, other problems, and also the patient feeling like they're sick because they have an open ulceration. So what about patient-focused outcomes? Now, most wound care studies that have tried to do this have actually not shown a statistically significant difference in how the patient felt, because there's so many other things going on with the patient. The patient may have an open wound, but they also have diabetes, or they have to go to a dialysis center, or they have other portions of their life that are not good. But in this group, the patients actually had a whole host of things that worked out well. There were actually no significant side effects from the treatment, obviously. There were no increased risk of infections, etc., from using the IDRT in the outpatient setting. And there's no statistical difference between the treatment group and the control group for safety. Now, most notably, versus a lot of the other therapies, and I realize, again, the Canadian market is somewhat different than the U.S. market, where we have a saturation of therapies for diabetic foot, but many of our therapies require 5, 6, 7, 8 applications, even in the effective or in the efficacy trials, in the ideal patient trials. Whereas in the IDRT therapy, in this particular trial, 72% of the patients that healed with only 1 application, and then only then of the patients who healed, 92% required a total of 2, or an additional 20% required a second application. The primary reason for that second application was actually shear or non-securing of the IDRT during the therapeutic period, which probably speaks to adequacy of offloading and also learning curve. That wasn't really looked at in the trial, but I think it would be interesting to go back and take a look and see if a lot of those second applications occurred in the first half of the trial versus the second half of the trial, and maybe that could occur as a post hoc analysis. Now, recurrence was evaluated in only the healed patients, which was really a much smaller population. And so there was this was not powered. The study was in no way powered to look at this as a question. I think a lot of us, and probably a lot of you in the audience, feel that closing things with a dermal regenerative substrate that's more like real dermis is going to give you a better long-term outcome. Again, this study was not powered or designed for that. The patients who healed, there were 79 patients who healed in the treatment arm. 15 out of them, or 19%, recurred. In the non-treatment arm, 13 out of 49, only 49 patients closed, so 13 of them, almost a similar number, reopened, or 26%. Now, those obviously 19 versus 26 looks like a fairly big difference, but it's not statistically significant, and it's not powered for such. But one would be interested to see in a larger trial how patients would do, or maybe a registry, how patients would do with IDRT therapy. In addition, the patients felt better. They just plain felt better, which is really nice. The caregiver who takes care of these patients, and they feel really terrible when they have an open ulcer, especially if you take a 55-year-old male who's busy trying to sell houses in New York City, and he really feels like he's not himself because he's got something seeping out of his foot. He can't wear normal shoes, and quite frankly, you get him closed, and he feels like a new person, and it makes a big difference. So you're happy the wound's closed, but these patients were more functional. They were significantly improved in multiple areas. They felt better, and they were socially more able to participate in their normal activities of daily living. So physical functioning improved, activities of daily living improved, their bodily pain improved, and their reliance on caregivers improved. So in closing, the Founders Trial is the largest published study that's looking at CTP therapy for diabetic foot ulcers, prospective randomized trial that showed accelerated wound healing, larger number, and faster, and really the majority were treated with a one-time therapy, or as we like to think of it, as one and done. Health economics, it was less expensive, the patients had many fewer visits, and they did better over time. So for a patient like this gentleman, you take a look at this small ulcer and you think, gee, that's not that bad, we can just fix it, but when you actually debride it, you can see how much larger this gets. Then has IDRT therapy placed on it, stapled in place. At 1 week, you can expect to have somewhat of an opaque haziness that you can't quite figure out what's going on underneath it at week 1. At week 2, the silicone comes off. We continue with weekly adaptic changes, didn't change anything else, and then by week 9, fully epithelialized with no secondary epithelialization strategy. So again, this is a 4 to 5 square centimeter ulcer that's able to epithelialize primarily. An alternative patient here, again, debrided widely. At 3 weeks, silicone is still in place. It's removed. At that 3-week period, continue to be treated with non-stick dressing, and at 11 weeks, complete epithelialization. You could certainly see or imagine how both of these patients would feel much better about themselves after having closed these wounds in this fashion. So there's other areas certainly that I use IDRT, heel ulcers, DFU in patients who that are challenged, which would not be in the Founders Trial, patients with end-stage renal disease, patients with exposed bone and tendon are certainly other categories. Patients with marginal perfusion, I don't feel terrible about it as long as I have some adequate tissue perfusion. Very punctate wounds, I use flowable dermal regenerative template into and have very nice results over that, including over bony prominences. Diabetics with venous stasis ulcers that can be widely debrided, and dehisced surgical wounds. So an outpatient heel ulcer may be treated in some fashion like this. And patient just is marginally debrided. That's actually her ankle you're looking at there, and her forefoot is moving away from you on the left of the screen. This was sharply debrided in the office setting, and then had dermal regenerative template stapled into it. As I said, I told people you must be fools to staple into the foot, and then I got these pictures out. I don't know, I kind of forgot. But when she went on to do well, 3 weeks the staples are removed, and at that point have something that looks like this, week 4, and then she actually went on to close subsequently. This is a diabetic foot ulcer patient who obviously has had significant resections, patient with end-stage renal disease, and we treat with them. You can see the, in this case, the IDRT stapled into the side of the foot. 24 or 25% area reduction just at week 4, so very fast reduction in patient with renal failure. For venous stasis patients, they often have too much pain to really get rid of their damaged dermis. You know, we're talking about IDRT therapy, so we're talking about regenerating dermis. So those patients will often be taken to the OR where they can have adequate analgesia. Now this patient, if you actually took this patient and tried to treat them as an outpatient, they'll actually never heal. The data on that doesn't exist because these wounds are bigger than patients usually have articles written about them. Take them to the OR, debride them, place IDRT therapy, their pain goes down significantly, we regenerate a dermis, and then we'll often use a secondary procedure to close them with an epithelialization strategy. This is a patient just exemplifying the difference between this who had, this was sort of a experiment of mine, but this is actually on a human, we treated with dermal regenerative therapy, and the middle portion of their wound there, you can see they had a circumferential wound, and that middle portion of the wound doesn't have IDRT therapy on it at all. And the real reason for that was at the time we ran out of it. We just didn't have enough, so it wasn't truly an experiment, but we just didn't have enough material. And you can see the difference in thickness of the neodermis between the two areas there, and this was taken prior to skin grafting. For outpatient treatment, we do at times use IDRT therapy in smaller wounds, and we'll affix that in a venous stasis ulcer just with steri strips, and then use compression over it. And you can see again epithelialization, which we again really think occurs in wounds that are probably smaller than 4 to 6 square centimeters. We don't see it usually in larger wounds than that. And then, as I showed you this case earlier, this is a patient who had needed dermal reconstruction. This is an avulsion injury after being run over. This is basically hospital hour 16 or so. They'd had all their skin cut away to make sure we had viable margins, taken back to the operating room, and then we went ahead and placed IDRT therapy with pie-crusted negative pressure wound therapy. Then at day 21, took all the silicone off, and you can see some of the staples still in the skin graft on the right-hand side after skin grafting them, and that would have been, that's still at post-op day 4 from the skin graft over that. So for us, we think that there are some things we have to pay attention to, especially in the U.S., as we get closer to really having to look at the cost of our therapies. I think we have to be concerned about the cost of closing the square centimeter of a wound. CMS hasn't come out with that at the moment, but I think cheaper therapies or less expensive therapies that close wounds faster and at lower cost, so with single application, matter. I think that there's ways that you have to be, that you have to expect, that we have to do better. We have to be able to close things at better than 50% averages. As a vascular surgeon, I always say if I went and told a family member I'm going to do your mom's carotid endarterectomy and she has about a 50% chance of being better in the next year, they would run out the door, and I never do carotid endarterectomies. But we sort of expect that in wounds, and it's not the right expectation. I do think that a strategy revolving around dermal regeneration, because of the depth of the wound, is important, and I think a lot of us have spent too much time thinking about epithelializing poorly functionalized tissue. And then you really want to make sure your strategy meets the wound type. You know, is wound type, what's the deficiency in the wound, and one is not going to be good enough for all. It's not one-size-fits-all therapy. So I think the way to think about this is venous leg ulcers that have been present for more than 1 year and then have a size greater than 10 square centimeters are candidates to go to the operating room, be debrided, and have IDRT therapy placed as a way of jumping onto this. It's not specific to IDRT therapy, but last year we published in the U.S. a paper looking at patients with venous stasis ulcers greater than 200 square centimeters, which there's no literature written about. And if you treat them for 6 months in the U.S., you spend $24,000 on them in products and home care costs, and they have no closure. If you take them to the OR and close them with a skin graft, not saying IDRT, but with a skin graft, it actually is $24,000 and they close. So I think there's a reason to take some of these difficult wounds to the OR sooner and close them, and IDRT therapy fits in very well there. Diabetic foot ulcer patients that have been open longer than 2 months, size greater than 2 square centimeters, and a Wagner grade of 2 or greater, really should be thought of for going to IDRT therapy at an early time phase and not waiting so long. One of the things that I think we're all somewhat guilty of, and this algorithm speaks against it, is that we should think about closing things much sooner, and we shouldn't wait as long for failure of conventional therapy because it leaves too many people out in the cold. So with that, in closing, thank you very much for your attention. I'll be happy to answer any questions.
Thank you, Dr. Lantis, for your excellent presentation and for some of those rather challenging slides, particularly for those people who may be viewing this presentation while you're eating your dinner. So I do apologize for that. We now have time for questions, but before I hand over to the moderator, I'd like to ask a question of my own. You mentioned in your presentation that you had been using IDRT for some time. Why did you start to use it?
We started using a dermal regeneration. To be completely fair about it to some degree, some of the people who trained me probably had a lot of background in IDRT therapy, so I might have been a bit more comfortable with it even coming out of training, and I think that is true of anybody who learns a technique. But part of it was the realization that we had a lot of wounds that their functional status wasn't very good over time, and that in general what was happening was that you could get something to heal and you'd look at it and it had a fairly temporary epithelial border. And I noticed this in our post-trauma patients over tendons and over bones and such, and therefore really wanted to regenerate a dermis that would work and hold up to pressure, etc. over time. This is also very true in diabetic foot ulcers.
Thank you. So I'll hand over to the voice of God, i.e. the moderator, who will field some of the other questions that have been put forward.
Okay, thank you, Doug. So our first question, in the ideal situation, what would your triggers be for treating a patient with IDRT?
Well, I believe the algorithm that I showed before is somewhat along those lines, but it depends on the type of wound. But certainly I think one of the things to think about is in the outpatient wound setting, when you have a patient come into your practice for the first time, you have to define what the first time is. And in the U.S., for us, it's often that the patient's been being treated for 8 weeks, so they really have already failed a lot of therapies. So it might be nicer to, in that setting, if they're a full thickness dermal wound, no matter the etiology, make sure you figure out the etiology and you're treating it. Prep the wound bed so it's clean enough, and that's usually going to take you 2 to 3 weeks, and then use your IDRT therapy. So I think the trigger is not so much the wound type, but what the wound looks like and what it's missing, and making sure that you can prepare it. Now, sometimes we're worried about using certain therapies because the wound is quote-unquote too deep. Now, in the ideal situation, and we have limitations on what we can do outpatient, inpatient in the U.S., but IDRT therapy really doesn't have a too deep in it. So that's not a limitation. I also think that immediately anything that has a tendon exposed, anything, a sliding structure, ligaments exposed, joint capsule exposed, IDRT therapy is an immediate choice because you're going to protect that wound very quickly and decrease moisture imbalances that might make that joint or that tendon never work again.
Okay, our next question. Is there anything specific that you do to prepare a wound bed for IDRT? And what are the requirements for vascular supply? And following that question as well, what is your protocol for secondary dressings and dressing changes? And there's one more part to this question. How often do dressing changes need to be done?
It sounds like one of those academic questions. Someone stands up and asks you 4 parts. Would you like me to answer that in forward or reverse order? Okay, so the wound bed preparation. Wound bed preparation should occur, I think it usually should occur sharply. It's almost never do we not debride immediately prior to applying IDRT. In general, IDRT should have sort of a misty bleeding to it. You want to have those cartoons I showed of fibroblasts and cells moving in, platelets moving in, all of that. You want to have some of that blood coming from the wound bed at that point in time. You also want to make sure that that wound has had adequate control of its bioburden. So depending on how dirty the wound was to start or how chronic the wound was, and you may need to use either topical, well, the topical antimicrobial, whether that's a silver or an iodine-based product for 2 weeks or so to prepare the wound bed so you get your best results. As to the vascular supply, obviously maximizing the vascular supply of any wound enhances its ability to heal, and we'll do all the things angiographically. I think if you have a patient who has, if you're not a vascular specialist and you have a patient who has no palpable pulses, etc., in the lower extremity, they obviously should see a vascular specialist to be assessed for tissue perfusion. If you have your own tissue perfusion metrics, that's okay. As far as dressings, in general, IDRT actually has a silicone backing, so quite frankly, you could probably put a lot of things on it and not have a real problem with it. But in general, we use a non-stick barrier to that. There are some tricks around things. If you use foams, you should use an open cellular foam. Open cellular foams are the ones that fill space and can act as a bolster themselves. We traditionally, for diabetic foot ulcers, use a Vaseline gauze type of product, the commercial name being Diabetic. We use a moist gauze over that and a self-adhesive wrap over that, which is sort of what was used in the trial. For venous leg ulcers, we use IDRT under compression, and for inpatient hospitalization with IDRT applications greater than 40 square centimeters, we almost always use negative pressure wound therapy as a 4-day bolster.
Okay, and there was just the last part of the question is how often do dressing changes need to be done?
I knew I'd missed one part of it. For IDRT, our protocol is fundamentally put on as an outpatient. We wrap it all and we write all over the outpatient dressing, do not touch, do not change, and we change it in 1 week. We don't let anyone get to it. In the inpatient setting, we change the negative pressure wound therapy over it after 4 days and then move to a secondary dressing. The first 2 weeks, we do weekly dressing changes, and after that, we'll allow people to do more frequent dressing changes, possibly 3 times a week. But we're actually okay with leaving it on weekly for up to almost the 1 month period.
Do you use negative pressure wound therapy, and how is it different than IDRT?
So I've been talking about negative pressure wound therapy in conjunction with IDRT. So obviously, I use a fair amount of it. Negative pressure wound therapy shows its primary benefit in reducing, when it reduces the area of a wound, it reduces actually the depth of the wound predominantly, or it reduces, I should say, it reduces the volume of the wound by reducing the depth about 75% and the area by 25%. So in other words, it fills space. So at times that there are cosmetic depths that we'll use negative pressure wound therapy for a period of time prior to using IDRT therapy. I have started to change that protocol a little bit. I have a variety of, I think dermal regenerative templates have the potential to help fill that space, so we're using more and more IDRT therapy with negative pressure. But negative pressure wound therapy, one other place is in massive wounds that are very badly colonized. You can use negative pressure wound therapy with installation for 1 week's time. That's an inpatient therapy. We do a debridement, 1 week of negative pressure with installation, and then we put our IDRT therapy on at the end of a 1 week period with an additional 4 days of negative pressure wound therapy. So they're in-house for 11 days. So there's a couple different ways of using it.
Okay, our next question. How does the Founder study relate to real-life DFUs, and what does the data say about using IDRT with other chronic wounds? And there's a second part as well. What has been your experience in using IDRT with other chronic wounds? If you need anything repeated, just let me know.
Okay, thank you. So I think I alluded to it. The Founders trial is, again, an efficacy trial where the patients are ideal. So I think the one thing to keep in mind is you want to maximize the quality of your outcomes. And everybody says, oh, we offload everybody, and everybody says, oh, we make sure everybody's hemoglobin A1C is under control, and everybody says, and I'm not picking on anyone, but the patient who is 6'6" and I guess, well, I'll switch it into kilos, but 200 kilos is a hard patient to offload. And so you have to choose your patients correctly. And remember, the patients, as you saw in the Founders trial, all have hemoglobin A1Cs under 10. They're all wearing offloading devices all the time. So you can't expect the same results in the real-world population as you do from a prospective randomized trial for any type of therapy. And I think that's just what you have to keep in mind and extrapolate that data outward. As to the second part of that question was other types of wounds. And certainly for dehisced surgical wounds, IDRT therapy can be ideal, especially wounds that have depth to them. Wounds over bony structures, a classic for us would be, say a patient has had a below-knee amputation and then falls on it and has protruding tibia. We use IDRT over therapy. I used to use tissue expanders on either side of the tibia, grow the skin, and then do a Z-plasty, which was 3 operations, very cumbersome, and you still got some wound breakdown. Now I just fill it with IDRT, 4 days in the hospital, and then they go home, and I take the silicone off. And I'll say that this very nice patient had this experience this past week, whose daughter takes care of him, literally when I took the silicone off at day 14, said, "That's amazing. That looks wonderful." And she's like his nurse, so I felt good about that. But also for venous stasis ulcers, it can be very useful. But I would say the thing with venous stasis ulcers is that in general, they really warrant good wide debridement prior to using IDRT therapy, because a lot of what you see in a venous stasis ulcer looks very superficial, which is fine. You can epithelialize it and get the patient under control. But if it's really deep, that dermis is completely, and I've looked at this histologically, that dermis doesn't look like dermis, it's scar. And you should get rid of it and try to regenerate better dermis. So that's how we go about venous stasis ulcers.
How much of healing in diabetic foot ulcers do you believe is product over offloading and stable A1C without vascular complications?
I think that offloading, ideal offloading, is paramount. And I think in places that do things like total contact casting and do a very good job, and we all know that total contact casting is always going to be somewhat biased, because you can't total contact cast everybody. But if you take patients with fairly normal feet or not terrible Charcot and no active Charcot, do total contact casting, they're going to heal pretty well. And we know what that data looks like, and that data looks like about 60% or so over a period of time. With that in mind, adding a dermal regenerative template in that with adequate offloading is going to be significant and make a significant improvement most likely. So I think we still have to be, our goals here should be to heal 99% of people. So with that in mind, the Founders trial, what it's looking at is good offloading and using IDRT therapy, but in no trial, and I'll tell you, there's not a single diabetic foot ulcer trial that is using a product and also uses total contact casting or even PTBs, and good, because you can't enroll patients in those trials. These patients will refuse to wear a cam walker or a Royce walking type boot. So trials always have moderate offloading in them. But ideally, if I had my druthers, total contact casting put on by the right people in conjunction with IDRT therapy, in conjunction with patients having very aggressive control, probably with a endocrinologist as part of the team, with the goal of a hemoglobin A1C of 8 or less. And if we could do that with all our patients, we'd start hitting 95, 96%. But we're not doing that. So,
what impact do you think biologics have on, or biologics like IDRT have on chronic inflammation?
I showed you Dr. Gottlieb's paper, and he's probably the person who's done some of the most work on that. I'd say certainly anecdotally, I have lots of cases of things like pyoderma, gangrenosum, which it's very clear that when you have a patient that has pathogy or autoinflammation, that when you debride the wound gets bigger. There's real, there's a real evidence that those patients, when you debride them and you put on a biologic, their wound doesn't get bigger. Pathogy goes away in the setting of using an appropriate biologic. So there's a very significant clinical impact, and there's also a very significant histologic impact. And really, I have to, in some ways, give credit to Mark, Dr. Gottlieb, for having talked about this so much and shown such good histology, really at his own interest. He's a plastic surgeon, and it wasn't at the behest of a commercial company, but he just noticed over years, many years of treating these wounds, that the inflammatory markers of when you did a debridement and you didn't put a biologic in a human patient and you did a biopsy would be very high, and there'd be a lot of inflammatory cells. And if you put IDRT in there, there were no inflammatory cells. So there's certainly a recognition of self or recognition of something else that goes away. I don't think that's fully explored. I do think that in patients who have significant pain from things like vasculitis and nature and maybe cryoglobulinemia, certainly from pyoderma gangrenosum, all those patients probably should be debrided and treated with IDRT, because there are very nice cases, again and again, multiple anecdotal cases. So we do that at our place.
Okay, our next question is our final question for the session. Canada has a very different healthcare system compared to the U.S. in terms of reimbursement. What economic impact do you think using an advanced therapy like IDRT could have on the Canadian system?
Yeah, it's a funny question, because there are probably places that I understand. I have a fairly good understanding, I think, of the Canadian healthcare system, and I think it matters really differently maybe in countries where there's a huge cost of living difference. That might be different. And when I lecture in Asia, that's a different question, because in Canada, the cost of things are actually fairly similar. It's really that people look at them differently. So a home care visit in Canada is still 60, 70 Canadian dollars. I just got that data today, and it looks like that's data from Ontario in 2013. So that's real money. And I realize that's spent differently in Canada than if it was in a hospital setting, etc. But it's still a global pool of money that's being spent on a specific problem. And if you can make that problem go away faster, with better results and less recurrences, it's always going to cost less no matter what. Now, it does matter how much a product costs to do that. If a product cost $1 million and healed everybody, well, you still couldn't afford it. But if a product's reasonable within the context of the number of visits saved and possible complications prevented, such as inpatient hospitalization, which we know in the U.S. a cellulitis admission is about $25,000. And the reality is our systems aren't that different in a way, because a large amount of these patients are paid for by the state. And the nurses, yes, they're going to be there whether they're taking care of this patient or some other patient. But the reality is that how things get paid for is very different maybe in the countries. But the money, the way it's spent, and even our populations are fairly similar demographically. And I think that some of the same impacts are true. There are nuances to them. I do think the place that it's a bigger difference is if you go to somewhere like Vietnam, where a nurse on average makes $3 a day, that then the cost of products can be really out of whack. Because if a person's annual income is $800, then the cost of health care has a completely different picture than Western countries. But I think that it's not really that dissimilar between the U.S. and Canada. I think there's lessons to be learned on both sides of the border by looking at how to reduce costs and improve patient outcomes.
Okay, so that finishes our question session. So on behalf of the Canadian Association of Wound Care, I would like to thank Dr. John Lantis for his presentation. I would also like to thank you, the viewers, for your excellent questions. We hope that this webcast has provided you with some useful information on the Founder study and how to treat wounds with the Integra Dermal Regeneration Template based on Dr. Lantis' experiences. I would like to remind you and encourage you to complete the online polling questions if you've not yet had a chance to do so. I would also like to remind you that we have an upcoming CAWC conference in Niagara from the 3rd to 6th of November, so if you haven't already registered, please do so. And I'd also like to remind you, as you've seen on the screen, if you wish to find out more on the Integra Dermal Regeneration Template, then please visit them at booth 616 at our conference. And with that, I'd like to thank you again and hope you enjoy the rest of your evening.